This we saw in the last class. We saw up to ECMO, isn't it? Last class.
Yes, sir.
Yes, sir.
Did we see this? Did we have this slide?
Yes, sir. We had, sir.
Yes, sir.
About this pharmacology question, did we have?
No, sir.
No, sir.
Okay, right. What are the different routes of drug administration? It's asking on pharmacology.
Oral, intramuscular, intravenous,
Subcutaneous.
transdermal, subcutaneous,
Nasal, sir.
rectal, intranasal.
Sublingual, intrathecal. Okay, so many
Yes, sir.
things. Oral, IV, inhalational, sublingual, rectal, transdermal, epidural, intrathecal. All these things are there. What is bioavailability of a drug?
The percentage of drug available after the first post metabolism compared to the initial dose of the drugs.
The fraction of administered drug reaching the systemic circulation compared to when the drug is given by IV route. Okay, that is a comparison. IV route is 100% available, isn't it? We are
Yes,
directly putting it into the bloodstream. So, what is the fraction administered by other routes when compared to the IV administration? Is what is called the bioavailability of the drug. So, what does this graph depict and what can be deduced from this? You have IV administration where plasma concentration shoots up immediately and then starts declining. Where another one you have the oral administration where it gradually the plasma concentration increases to a particular level and then it starts declining. So what do you deduce from?
Bioavailability, sir. In intravenous, it is 100%
bioavailability.
bioavailability.
It shows the time of plasma concentration area under the curve.
This graph depicts the area under curve, AUC, for oral and IV dose. That is the answer for this. So this graph depicts the area under curve for oral and so bioavailability of a drug can be calculated by area under curve of oral dose divided by area under curve of IV dose. That is how the calculation is done. What is first pass metabolism?
Before reaching the systemic circulation, it undergoes metabolism in the liver.
Liver. Is it only in the liver or somewhere else also it can happen?
No, so any site in the body whereby it undergoes metabolism before reaching the systemic circulation.
It can happen in the bowel wall or hepatocytes. Okay, it is a metabolism of a drug before it reaches the systemic circulation. And it need not be always in the liver. It can happen in the bowel wall also. How first pass metabolism can be avoided?
By IV administration, sir.
By
Intravenous administration.
Very good. Then any other route?
Sublingual.
Sublingual.
Oh, sir.
Buccal, sublingual, nasal, rectal, transdermal. All these routes. IV, of course, is 100% parity. But if you want to avoid first pass metabolism by other route, you can use sublingual, buccal, nasal, rectal, and transdermal. All these things do not go to the liver or the problem is there. What route of administration is shown here and what drugs are given by
Transdermal patch.
transdermal route?
Contraceptives.
That can be used are fentanyl, nitrates, buprenorphine, and estrogen. Mention pros and cons of this route. What are the advantages? What are the disadvantages?
Pros is it's non-invasive, sir. We need not
Very
poke the
good.
patient.
Con?
Con is
Get dislodged, sir.
start acting only after an hour or so after we place the patch.
delayed absorption, and skin irritation. Easy to administer. Ideal for this, we do not tolerate oral, low sustained release are the advantages. Disadvantage, inconsistent absorption, delayed onset, need to keep changing the site. The patient undergoing DA develops this change in the CKG but is stable. What is seen and what would you do?
Premature ventricular complexes.
Very good. Multiple ventricular ectopic seen. When the patient is stable, just observe. Occurs in run of 5, then what is the first choice? Lignocaine 1 to
Lignocaine 1.5 mg per kg.
If this condition degenerates into ventricular tachycardia with a palpable pulse, what to do?
If the patient is stable, we can go with antiarrhythmic drugs like beta blockers and amiodarons.
So assess hemodynamic status. If unstable, get ready for the defibrillation to correct the rhythm. So it
Yes,
is
sir.
not just palpable pulse may be very feeble also. Okay.
Yes, sir.
So you have to assess the hemodynamic status. If unstable, that the BP is low, then you have to get ready for defibrillation. The patient becomes unstable, what steps to be done?
Immediate
Deteriorated.
defibrillation and airway breathing and circulation.
Very good. Start CPR first of all.
Yes, sir.
Then defibrillate it 150 to 200 joules of stop. Start using antiarrhythmics like amiodarone, magnesium sulfate to find out the cause. What are the types of ventricular fibrillation? Which one has a better prognosis?
Monomorphic and polymorphics.
Monomorphic and polymorphic. Okay, out of which one has got a better prognosis? Monomorphic and polymorphic, do they ask for prognosis or some other type of classification is
VT, sir.
considered for?
Pulseless VT and with pulse.
Force and fine. These can be force fibrillation or fine fibrillation. Force has a better prognosis because it is closer to normal heart activity. So what is the refractory ventricular fibrillation?
Even after treating with 2 antiarrhythmics, if the ventricular
Antiarrhythmic or
fibrillation
defibrillation?
persists, sir,
With antiarrhythmic or with defibrillation? The fibrillation continues after 3 successive defibrillations. It is called refractory. There is no role for oral antiarrhythmics or IV antiarrhythmics. With a failure of defibrillation after 3 attempts, it's called refractory. So what to do if there is evidence of acute myocardial infarction in a patient with ventricular fibrillation?
can give him a loading dose and then you can do coronary
What is the
angiography.
current concept in ACS? Revascularization as early as possible, isn't it?
Yes, sir.
Myocardial infarction is dangerous because there is no blood supply. So you have to establish blood supply. So urgent PCI may be needed if condition does not improve. Okay? Because they take up patients who are even pulseless for PCI. What is shown in this picture?
Cardiopulmonary exercise testing.
Excellent. Cardiopulmonary exercise testing. What is the purpose of this test?
To assess the cardiopulmonary reserve.
Cardiopulmonary reserve, sir.
Okay. It's a non-invasive way of testing the functional ability of the heart, lung, and musculoskeletal system. Not only the heart and lung, it is also affecting the muscle strength. What factors determine the exercise tolerance?
Sir, maximum oxygen consumption and the maximum heart rates.
What factors determine exercise tolerance? Pulmonary gas exchange, cardiovascular function, and skeletal muscle metabolism. Okay, these are the three things. So, how is Fick equation important in cardiopulmonary exercise testing? First of all, what is Fick's equation?
No idea, sir.
No idea. Fick equation states at rest, oxygen uptake is the product of cardiac output times the arteriovenous oxygen difference. Okay, very good. So it is equal to volume into heart rate is cardiac output
Yes.
multiplied by arterial oxygen content minus venous oxygen. Okay, that is the oxygen uptake. So this only determines the cardiopulmonary exercise testing. So how is oxygen uptake expressed? How much is one net?
Uh,
One metabolic equivalence is equal to 2.5 ml per kg per minute.
3.5 or 2.5?
3.5 ml per
3.5
kg per minute.
and per
So
kg per
O2
minute.
is expressed as oxygen per kilogram per minute. So one net is 3.5 ml per kg per minute for a 70 kg person at rest. It is not during exercise. Okay, this is a very important objective that we have to use. What two important parameters are obtained by doing cardiopulmonary exercise testing?
Maximum heart rate achieved and maximum
That
oxygen
is
consumptions.
ventilation perfusion.
What is anaerobic threshold?
Nice.
And beyond the tissue will suffer after
Maximum
the
oxygen consumption and ventilatory anaerobic threshold are the two parameters that are thing. So maximum how much of oxygen person can consume, how many minutes you can use, then ventilatory anaerobic threshold. That is about 11 to 12 millimole per kg per second. Beyond that, patient will go in for anaerobic metabolism. It's called the anaerobic threshold. Now, what is shown here? This graph.
Carbon dioxide transport.
Carbon dioxide dissociation
Dissociation
curve.
curve.
Carbon dioxide. This is just like your oxygen dissociation curve. You have a carbon dioxide dissociation curve also. So you have a curve for carbon dioxide. So what do points A and B mean in the graph?
So,
Point A is venous
Hmm.
PCO2 and point B is arterial
Okay.
PCO2.
Indicate volume of carbon dioxide in arterial and venous vessels. How much carbon dioxide is there in these particular points?
point A is 40,
If you
45
drop a
mm.
line here from here, you know. See from point
Point
B,
B 40 millimeter of mercury. Point
about
A is
40.
45 millimeter of mercury.
40 millimeter is 480 ml per liter at 46 millimeter and 20. Okay. How is carbon dioxide transported in the blood? What are the mechanisms of transportation of dioxide?
So
of
from
the
the
trans.
tissues, the CO2 and the water are taken inside the RBC with the help of carbonic anhydrase.
Hmm.
It is converted to
How many modes are there? How many modes of transport of carbon dioxide are there? Only one mode or
It's transported in three ways. So one is bicarb, one the dissolved form, and one is carbamino compounds.
Compounds.
there are three ways. That is the answer that you have given. One is dissolved fraction, which is 5 to 7%. Second is bound to proteins in hemoglobin as carbamino hemoglobin, which is about 10%. Third person major as a bicarbonate with 80%. These are the three modes of transport of carbon dioxide. What is hamburger phenomena? This is all basic physiology questions. Suddenly you will get all these things. Physiology, pharmacology. The hamburger phenomena or chloride shift. Okay? RBC, how it goes into the RBC, gets converted,
Next.
and bicarbonate is exchanged for chloride. That is how the whole thing is transported. Bohr versus Haldane effect. What is Bohr effect? What is Haldane effect?
So Bohr effect
tissue
is how
level.
high protons interact with hemoglobin and how they cause O2 to be displaced. When protons or carbon dioxide reacts with hemoglobin, they favor the T state where more oxygen is released than it is bound.
So Haldane effect describes the increased ability of deoxygenated hemoglobin to carry carbon dioxide.
So the correct answer is Bohr effect happens at the tissue level. Haldane effect takes place at the lung level. That is the first and foremost point. So when blood reaches tissues, the PCO2 partial pressure is more. So carbon dioxide plus water becomes bicarbonate, which breaks down into hydrogen and bicarbonate. Hydrogen increases, pH decreases because of decrease in pH, increase in PCO2, oxyhemoglobin dissociates into hemoglobin and oxygen. Oxygen released into the tissues. So Bohr effect is effect of carbon dioxide on oxygen transport at the tissue level. Whereas Haldane effect, when the blood reaches the lung, the PO2 is more, carbaminohemoglobin dissociates into hemoglobin and carbon dioxide. This carbon dioxide is sent into the lungs for respiration. So Haldane effect is effect of oxygen on CO2. So at the tissue level, CO2 helps the oxygen to be delivered to the tissues, and at the lung level, Haldane effect, oxygen helps the carbon dioxide to go out of the body. Okay? So the main point you have to remember is Bohr is at the tissue level, Haldane is at the lung level. And in Bohr equation, it facilitates oxygen delivery to the tissues by releasing the carbon dioxide taken up by the blood. And at the lung level in Haldane, it facilitates absorption of oxygen and release of carbon dioxide. The same thing happening. What is Sagan-Poiseuille equation?
The flow is equal to delta P pi r to the power of 4 by 8 meta L.
This is a formula that you are describing.
Where the flow is directly proportional to the radius and inversely proportional to the viscosity and the length of the.
Correct. Sagan-Poiseuille equation defines a flow through a tube, taking into consideration the length and radius of the tube and the viscosity of the fluid. So the applicable only to Newtonian fluids undergoing laminar flow. So what is the formula? If they ask you what is the formula, then you have to write what you described.
Yes,
But what is this equation? The definition for that equation is the earlier answer. So it is Q is equal to pi PR4 by 8 eta L. So Q is the flow in liters per second, P is pressure in Pascal, R radius, L is the length, and eta is the viscosity. Greek word eta, the memory, Pascal is second in SI unit. So what do you understand from this equation? describing the second partial equation, what can
Yes,
you
sir.
understand from it?
Increasing the radius even it
Flow
can
will
have an
be
impact up to
maximum.
4 times.
Very good. So flow of the fluid through a tube increases with increase in pressure and increase in radius of the tube. Okay, these are the two. So flow reduces if the viscosity and the length of the tube are more. So inverse happens. What are the applications in anesthesia of this equation?
So flow of a fluid through a IV set or IV cannula and the central venous cannula.
Okay.
Flow of gases through ventilatory circuits.
HCT or ETT?
ET tube, sir.
Tube.
So larger the radius of the ET tube, lesser the resistance to breathing, especially in children, number one. Larger the radius and shorter the length of IV cannula, with increased height, the flow will increase. Is shown here.
Neuromuscular junction, sir.
Very good. Very simplified diagram of describe the NMJ.
It has a
All the components.
presynapse, synaptic cleft, and the postsynapse. So
Very good. NMJ consists of a nerve terminal, synaptic. So it is a pre-synaptic. It should be said as nerve terminal, synaptic left and motor unit. Postsynaptic motor unit. What is the size of the synaptic left? This gap between the nerve terminal and the nerve site. What is this gap size? It's about 20 nanometers wide. Approximately. How many acetylcholine receptors present at motor enclave?
more than 1 lakh.
More than
10 lakhs.
1 to 10 million acetylcholine receptors present in each motor. What are the types of acetylcholine receptors?
Nicotinic and muscarinic, sir.
Excellent. Nicotinic and muscarinic. How many types of nicotinic receptors are there?
2
Are
types,
there any?
neuronal and muscular.
Neuronal, pre, post, and extra junctional. 3 types are there. Okay?
Okay, sir.
You have an acetylcholine receptor in the nerve terminal also, which only is blocked and decreases the release. And there is a post junctional and extra junctional acetylcholine receptors. How do nicotinic and muscarinic receptors differ?
Receptors are G protein coupled receptors, sir.
What about
Nicotinic
nicotinic?
are mostly ion gated channels.
Acting channel. Nicotinic or ion channel, muscarinic or G protein. How is acetylcholine broken down?
Acetylcholine esterase in the synaptic cleft breaks down acetylcholine into acetyl-CoA and choline. Choline is taken back into the nerve terminal through transport.
Terminal for again. Very good. What happens in myasthenia gravis?
Antibodies produced against acetylcholine receptor in the post motor end plates.
Very good. So it is an autoimmune disease where antibodies are produced against acetylcholine receptor, blocking its action, resulting in cell weakness. What happens in Eaton-Lambert syndrome?
Antibodies produced against the voltage-gated calcium channel in the presynapse nerve terminals.
It is a presynaptic activity. So it increases the release of acetylcholine itself. Okay? So presynaptic disorder preventing release of acetylcholine by blocking the calcium. How is the size trauma score calculated? Three things are taken into consideration: VCS, respiratory rate, and then solid B. So how is RPS used to triage trauma victims? Trauma anesthesia, people have not heard about it. So the score ranges from 0 to 12. The patient with RPS score of 12 is labeled as delayed or walking wounded patient. It is not, he will receive the least attention. He is a stable patient. 11 is urgent. Intervention is required, but the patient can wait a short time. The score is between 3 and 10. It requires immediate medical intervention. And the last possible label is marked, is given to seriously injured patient with a rate score of 3 or low. That means he is definitely going to die. So anybody with a 12, you can ignore them, you can make them wait. If anybody below 3, again you can ignore them because whatever you are going to do, you are not going to succeed in reviving them. So you must pay attention mainly to patients between having a score of 3 to 11. That is the triaging method. What is delayed sequence intubation? What is its algorithm? You have heard about rapid sequence intubation, but what is delayed sequence intubation in trauma? So here the delayed sequence intubation is mainly to optimize the hypoxic agitated patient before intubation. Okay? So the aim is to optimize the patient prior to intubation, particularly in the case of hypoxia and or agitation. So position the patient in a semi-recumbent 20-degree head-up tilt or ramp position. You can use nasal cannula or non-rebreathing mask if there is no facial injury. Consider ketamine for agitation. Consider CPAP for hypoxia. Allow 3 minutes breathing at a page volume of 8 or more breaths. Then induction. If the patient still needs intubation, assess their oxygenation, give sedative, hypnotic, and paralyzed. Then optic oxygenation to be continued with jaw thrust and high flow nasal oxygen and CPAP, and then intubate. Okay, so this is the algorithm to be followed for a patient who has hypoxemia and agitated. What is shown here and where is it used? Are you able to see this picture and understand? This is the chest of a patient. You can see the nipple, the hair, everything. This is the thorax. There is a transparent
Tension pneumothorax.
tension pneumothorax. So what is this called? What is shown here? What is the name for this? It is used for tension pneumothorax. You are right.
I see.
Prevent the entry of air from the atmosphere into the chest. This is called the three-sided occlusive dressing. So this is a transparent plastic paper or the bag that you can use, and then occlude only 3 sides and give a gap here. So how does it work? It does it in open pneumothorax. It is not in tension pneumothorax. It is done in open pneumothorax to prevent air getting sucked in, and the mechanism is like this. So when the patient breathes out, the air comes out through this gap. But when he breathes in, the atmospheric air is not able to enter because this film will stick to the chest wall and prevent the air entering and make it go. So it will prevent the open pneumothorax getting worsened. What block is being performed here?
Interscalene blocks.
Very good. Interscalene approach to brachial plexus block using peripheral nerve stimulator and catheter insertion for extended block. So all these things as you see, you can see this is the nerve stimulating needle mark with the mark. This is the catheter for insertion of continuous block. Okay. So what are the indications for this approach?
So shoulder and upper limb surgeries.
Very good. Surgery on shoulder and elbow. What are the landmarks and technique of performing this block?
So between at the level of C6, between the anterior and medial scalene muscles.
Crystalline groove. You have to calculate.
This one.
Position of the patient is supine with head turned slightly to the opposite side. Preparation all around the site of puncture. Palpation, lateral border of sternocleidomastoid. Identify the external gular vein. Palpate the interscalene groove. Then puncture, insert the insulated needle in a PID direction, backward, inward, downward direction. The point where EJV crosses lateral border of sternocleidomastoid. And what response you should get? Twitching of deltoid arm or forearm muscles with a current of 0.2 milliamperes indicates of activity. What are the complications of this block?
So pneumothorax, bleeding, hematoma formation, last local anesthesia, systemic toxicity, and
Phrenic nerve injury, sir.
toxicity.
Now, block. Can it go intrathecally?
Yes, sir.
Spinal injection, epidural injection, vertebral artery.
Vertebral
puncture,
artery injection. Yes, sir.
Pneumothorax is quite rare in this because it's quite higher. Nerve
Okay.
injury and phrenic nerve block. These are the complications. What is the risk of performing bilateral interstitial block?
Diaphragmatic palsy.
Phrenic nerve palsy.
Due to respiratory distress. What is shown here?
Color-coded biomedical waste management.
Waste management. Coded biomedical waste management bins. What is a biomedical waste? What is the definition of a biomedical waste?
The waste which is produced by dealing with the medicines or with the
Healthcare
human
system.
It could be anatomical waste and the chemical wastes.
Any waste is generated during the diagnosis, treatment, or immunization of human beings or animals or in research activity. That is the correct definition.
Yes, sir.
What items can be deposited?
Sir, in yellow color, it is
Human and anatomical waste.
anatomical tissues and soil waste, sir. In red bin, which is plastics. In blue color,
Recyclable items in red bin.
blue color, it is glasses, implants, and in black color, it is
Yellow bin for human animal waste, cotton, resins, linen. They are dispersed by incineration or deep burial. Red bin for tubings, catheter, IV sets can be destroyed by autoclaving chemical treatment. Blue bins for sharp waste, needles, scalpel, syringes. Which is done incineration, shredding or autoclaving. Black is for discarded medicines and cytotoxic drugs. Disposed secured landfills. So this is how they color coded. What are the sources of biomedical waste? Hospitals, healthcare centers, blood banks, biomedical research centers. So it means that this is where it can generate that. Okay,
yes, sir.
it's seen in this X-ray. Very easy one. I thought what will rattle off. How does the left border of the heart look like?
Straightening of the left heart borders.
Straightening of left border indicative of mitral stenosis. So what structures normally form the left border? The X-ray.
Most of the lateral border of the left ventricle.
Left border, lateral border, right border, left border, lateral border, field border. Left border is formed by aortic muscle, pulmonary bay, left atrium appendage. What parameters are used to assess the size of the heart?
Cross-sectional area of the valve, sir.
Valve size, pressure gradient across the valve, is Hartmann syndrome. What are its causes?
Because of left atrial enlargement, there is recurrent laryngeal nerve involvement leading to
Compression.
hoarseness of voice.
Very good. Any other condition which can cause this other than left atrial enlargement? So hoarseness of voice due to compression of Bachmann membrane nerve is called the Hartmann syndrome, and it can be caused by LA enlargement in the aortic aneurysm at the arch of the pulmonary artery dilatation due to pulmonary artery. All these three things can be used. What are the treatment options for correcting hyperstenosis? Interventional procedures, open procedures, and
Valvotomy, valve
Balloon valvuloplasty and valve replacement procedures.
What are the hemodynamic goals when anesthetizing patient? That is necessary.
You should avoid tachycardia.
Tachycardia, very good. Heart rate, preload optimum. Always remember 5 points. Preload, afterload, contractility, rate, and rhythm. These 5 points are considered as goals in any cardiac patient. So preload
Yes, sir.
should be optimum, afterload should be preserved, contractility maintained, rate should be quite slow, rhythm should be silent, not allowing to go to epilepsy. The last one, what is shown in this USD image?
The image
Can
is
you
not
share this
so visible.
screen, sir?
The screen
Can
is
you
not
please share this
visible.
screen, sir? Screen is not visible, sir.
Not visible. Visible now?
Yes,
Sir.
sir.
Using
Yes,
token.
sir.
Is visible now?
Yes, sir.
Yes, sir.
Can you identify what are the being shown here?
Obturator nerve block, sir.
Excellent, excellent, excellent. Ultrasound image of anterior and posterior branches of the obturator nerve. What are the indications for obturator nerve?
In
PURP
PURBT,
and
URBT, knee surgery, hip surgery, hip adductor spasm, pelvic pain therapy. What is the root value of obturator nerve?
L3, L4, L5, sir.
2L3.
Very good. L2,
L2,
L3.
L2, L3, L4.
How is the landmark based technique of obturator nerve block performed? It's also called Labat. Last week we saw sciatic nerve also by Labat technique. So position the patient supine with the limb to be blocked, little abducted. That is the first point. Then palpate and identify the pubic tubercle. Insert a 22 gauge 8 cm long needle perpendicularly to the skin, 1.5 cm lateral and caudal to the pubic tubercle. Advance the needle until the inferior border of the superior pubic ramus is contacted at a depth of 2 to 4 cm. Once the bone is hit, you withdraw the needle slightly and redirect it capillard laterally to enter the obturator foramen and observe for adductor canal muscle contraction by using nose stimulator. Inject 10 ml of local anesthetic slowly with frequent aspiration for blood. A successful block will produce a impaired lead adduction in approximately 20 minutes after injection. These are all the properties for this class. Okay. Right.